Hi, everyone. I'm Grace Heppis. I'm the Outreach and Education Coordinator for the Duke Center for Misophonia and Emotion Regulation. Dr. Andrew Guzick he's made some really big strides in this field, especially for youth and parents with misophonia. And he's a clinical psychologist, specializing in misophonia, anxiety disorders, and OCD. He conducts research on these conditions at the Center for the Treatment and Study of Anxiety at the University of Pennsylvania and with the OC program at Baylor College of Medicine. His work has been supported by the Misophonia Research Fund, the National Institute of Mental Health, and the Texas Higher Education Coordinating Board. He has published over 100 peer-reviewed publications on these topics. Dr. Guzick now focuses on his private practice, where he provides cognitive behavioral therapy for children and adults affected by misophonia, anxiety, and OCD. Today, he is presenting results from 2 different papers exploring lived experience perspectives. Please welcome Dr. Andrew Guzick.
Thank you so much for that wonderful introduction. I'm so happy to be here. I'll actually be zooming in on one of those 2 papers because of how much time we have to run through things today. I'm really excited to talk with y'all today about this work because we actually really did this with the intention of understanding advocate and lived experience perspectives better, to get out there to researchers and clinicians and the scientific literature. So I'm really thrilled that I get to talk to you a little bit about what we learned and see how it lines up with your own experience. So the title of this work is Child and Parent Priorities for Misophonia Advocacy, Treatment, and Research. I'm presenting on behalf of the team that conducted this study, the Katie Abraham and Katie Ratz, Eric Storch, and myself. We started this work at Baylor College of Medicine, and then I moved to the University of Pennsylvania, where we finished. I will also do my very best to minimize triggers, but I do understand it's different for everyone. So apologies in advance if I am not totally sensitive, but feel free to do whatever you need to do to be comfortable, of course. Just to give you a little bit background on me, who's talking about this topic, I grew up in Rochester, New York, and then learned about misophonia when I was studying clinical psychology at the University of Florida. At the time, I was introduced to this. Please don't hold this against me, but I was interested in the hypothesis we had about 10 years ago, plus that maybe this was related to OCD in some way. I continued studying misophonia and was really happy to. When I went to Baylor College of Medicine for my postdoc, the first thing you do after your PhD, where I learned that there's a lot more to it, and I've really been focused on trying to understand it better since then, and have gotten to do more and more work when I moved to the University of Pennsylvania, where I've continued to conduct research and more recently opened a private practice where I'm really focused on serving people with misophonia as well as other conditions. So where were we when we started this a few years ago when we started this research? There's almost no research on misophonia in kids. Meanwhile, there are these new and growing advocacy voices online. Lots of parents of kids with misophonia looking for help, trying to raise awareness. Lots of kids with misophonia themselves beginning to advocate for themselves. Very few clinical specialists. That's certainly the case today still. And there was emerging research in disciplinary silos. What do I mean by that? It means like psychologists were doing psychological research, neuroscientists were doing neuroscience research, audiologists were doing audiology research, but they weren't really talking to each other. That's still often the case. And they weren't really often talking to people with misophonia to understand how to line up their research with what might matter to this group most. So our key question here was what matters to kids with misophonia and their parents? What did they want researchers and scientists to study? What kinds of treatments are they looking for? And what advocacy and policy efforts do they feel need to happen next? We were able to do this because of the generous support of the Misophonia Research Fund. I'm very grateful too that we got to pursue these questions. We pursued these questions with qualitative research, and a qualitative research mentor of mine shared this meme with me that I thought was funny. Because when I got into this, I was asking, is this even science if there are no numbers? I learned quickly that there's a really rigorous way we do qualitative research. So before telling you about what we found, I just want to give a little bit of an overview on how we make qualitative research consistent and reliable and scientific, even if there is more subjective interpretation compared to probably the rest of the presentations you'll see today. So I'll give a non-misophonia example to explain how qualitative research might work. Maybe we're doing qualitative research on, or qualitative thematic analysis on feedback of the presentations today. Maybe somebody said in their feedback, I really enjoyed this presentation, but the presenter is just a bit too boring for my taste. I'd prefer if you would have made a song about this research instead. So what we'll do is, before we read all of these, and as we're reading all of this feedback, we'll come up with codes, ways to categorize the feedback and the text. So maybe we'll have text that has positive impressions, what they liked, negative impressions, what they didn't like, any comments about format, and then maybe comments about what they learned. So we have a coder go through this text and they see, okay, I really enjoy this presentation. That goes with positive impression. They said it's too boring for my taste. That's a negative impression. And then I prefer if you would have made a song about his research instead. That's a comment about the format. We have a second coder go through, and we want to make sure these two coders agree at least 80%. And that 80% agreement is where it gets to be more rigorous and more consistent. And so we did find that across our couple of raters we had in this. So what do we do next? Once we get all of those text snippets that go with those different codes. So for example, here we're looking at these format comments. I prefer if you would have made a song about his research instead. I think interactive parts of the presentation would have been better. He should have used examples I could understand. We look at all of that text and then we come up with a theme. One thing we might say when we read all this together, it seems like the format led to a lack of learner interest. So I'll share this after I read all the text with my research team, with Eric and the Katies, and they'll look at this and they'll say, I hear what you're saying, that there's a lack of learner interest with that format, but I think really lack of learner engagement is a better way to describe it. So we come up with a report that has these themes, and then we share it with the people who gave us that feedback, and we ask, did we capture your voice accurately? This is what we did in our research on misophonia. So we did interviews with 20 kids with misophonia and their parents, and the big things we learned, I think many of these I anticipate, I hope will resonate with your experience, but I'm sure that there will be distinctions and nuances. Two things we learned about with advocacy, or two things we heard about a lot, was one, that we need more awareness. Two, that we need to help people understand that misophonia is a condition outside the child's control. It's not just a self-control problem, it's a real source of internal suffering. They had lots of recommendations for what we need to study, the neurobiology, understanding misophonia beyond sounds. Misokinesia is one example, but really the complex nature of misophonia, it's not just a sound problem. Understanding the daily impact of misophonia and the connection with mental health, understanding long-term prognosis. And what we also really heard, number one, for treatment providers was we need more practical and misophonia-specific therapies. I'll show some text that I thought illustrated some of these themes. One, we need to advance awareness for advocacy. Of course, we're talking about that today with Dr. Rosenthal's call to action. This is something we all need to be working on as much as possible to help misophonia become more recognized. One child said, I think there needs to be more awareness about it so that people with misophonia can be open about it and explain it to people. And it's not like everybody gets all weirded out. So those people feel comfortable being in public and being like, hey, do you mind not eating in class? We're taking a test. I'm really trying to focus right now. This really bothers me. But, I feel really reserved to say anything like that. I know working with people with misophonia, this feeling is so consistent and such a big challenge. Misophonia is outside the child's control. This is a parent making this comment. I would want people to know that it's an involuntary reaction because my mom, this child's grandmother, has thought that she's having bad manners or that I'm not disciplining enough. When so much of, although this is certainly the case in other conditions, when we have a name for something, when it's recognized as a real condition, people have a better understanding that this is a source of real internal suffering, not just a discipline problem. In terms of treatments, our participants were advocating for more practical and misophonia-specific therapies. I pulled this first quote because it hit home with me in a way I used to think about misophonia to some extent. It's currently being treated, in our case, as anxiety, and it's a very specific issue that I think needs its own specific therapy. There are certainly lessons to be learned from treatments for anxiety for people with misophonia, and it's a totally distinct problem, and there are complete differences. And I will say, when I talk to therapists and clinicians, this opinion is often common. This is the perspective a lot of people take. So that was one quote I felt I need to pull to really speak to the clinical research community, the people who do research who are also seeing patients and clients. I'd just like to see technology that really works. You're not walking around with these giant headphones on, something that's discreet. Of course, there's been a lot of progress in this area, and there's clearly a need and room for improvement in the sound management side of treatment as well. Lots of opinions about research. For example, on the neurobiology of research, understanding what's happening in the brain. A lot of work's being done in this area, and it's certainly perceived by this community as a brain-based problem, at least in part. And also that it's not just a sound problem, defining misophonia beyond sound triggers. This quote that a parent said, I think, really captured the multisensory and emotional complex experience of a misophonia reaction. She can still hear the sounds through the floor and stuff. I'm like, is it a sensation? Is it visual? Is it a feeling? Is it a combination of feeling and hearing and seeing? I thought this was really a poignant quote that spoke to how this is not just a sound processing problem, it's a complex problem that involves lots of different components. They were advocating for investigating how misophonia affects people's lives, help the family too. I think we have to start with the person, but then eventually work with the family because it's huge in family systems. Really understanding what misophonia is and what a severe impact it can have on the quality of life for someone is the most important thing, something someone else said. The misophonia mental health connection. This is one quote about how misophonia impacts mental health. I think they really need to be looking into the anxiety and the depression that also comes with this, because you get so in your own head and you're like, I'm so alone because no one understands what I'm going through. And finally, one parent commenting here on prognosis. This is a quote we pulled, but this is something that we heard over and over again. Is this something that you can anticipate is going to get better with time, get worse with time? That data is something that if I knew as a parent, I could feel like I could better prepare my child. Those efforts are underway, but it's really hard to do research like that. It's going to take a long time for us to get there, but it's certainly something I think all of us want to know better. We all have our own individual experiences with how things have gone over time, but following a group of people over time will give us a better sense of what the different pathways could look like. So why does this matter? Why is it important that we gather these families and we learn from them? One reason I think this matters is that publishing these priorities in scientific journals like we did might give researchers ideas on how to make sure their research is as helpful as possible. Sometimes researchers come up with lots and lots of interesting ideas. Sometimes those ideas line up perfectly with, say, what people with misophonia need. And sometimes maybe they don't. Maybe they're just interesting studies but aren't going to actually help too much. But we hope that getting this out there will really encourage people to take a step back and look at what they're doing and try to understand if it lines up with what's most important to the community of people who it's going to affect most. I thought there were important ideas for advocates, healthcare professionals, and researchers that arose across the interviews. The good news is why I feel optimistic is many of these line up with the Misophonia Research Fund priorities, the efforts that soQuiet are engaging in, and the other the other advocacy organizations and other players in this area. All that said, the flip side of that coin is it really does show there's so much room for improvement and that we need more progress. We've made progress since we did these interviews probably about 3 years ago, but of course there's still a lot more to be done. Lots of thank yous. There's a big team involved, but I'll really highlight the Katie's, Abraham and Rast, and Eric Storch, Baylor College of Medicine and University of Pennsylvania, who helped support this research being done, as well as, of course, Misophonia Research Fund, who generously sponsored this research, and soQuiet, Duke CMER, and the Misophonia Research Network for hosting today. All right.
Thank you.
Thank you, Dr. Guzick. Going to pull up some questions. This is from Hannah. The links between OCD and misophonia are interesting, but I'm extremely fascinated by the link between hypermobility/connective tissue disorders and this impairment of auditory signals. Is this a path researchers here in the U.S. are also exploring?
You know, I cannot say I've heard of anybody exploring that particular pathway, if I'm being totally honest. Maybe one of our other panelists has. But no, I can't say. I'd be interested to learn more.
Thank you. From Sandy, wouldn't noise pollution be a logical term to use when referring to misophonia triggers? I.e., so that when we're discussing misophonia with the general public, they more easily understand what misophonia sufferers are going through.
That's a really interesting perspective. I think I think it certainly could. I think and that's a really great perspective from, I think, a public policy standpoint. You know, you hear a lot about sensory safe spaces for the autistic community. I'm thinking about that sort of lens. That noise pollution is a form maybe of not an accommodating space from a sensory perspective. That said, what I'm often working on helping people I work with is not only on describing the noise, but also their own experience in a way that is effective and helps and actually facilitates a good conversation. You know, finding terms that people might receive really well, like I'm feeling overstimulated or I have a sensory issue, and one of the things that really helps is when such and such happens. That way you're centering yourself instead of putting it on somebody else, and which can unfortunately generate some defensiveness when there isn't good awareness around what this is.
We're at about 5 minutes, Dr. Guzick.
Okay. 5 minutes left.
5 minutes left, yep.
Okay, understood.
Next question I have is from John. What is the differential when autism is involved?
Oh, yeah, 5 minutes. I could probably spend a full 5 minutes on that answer. I'll try to be really as efficient as possible. Autism, to make a diagnosis of autism, you're looking for a whole constellation of differences. Social communication differences are what is often thought of as most central. You know, differences in understanding, communication and relationships and emotions. And then there's a whole array of other autistic features that are often put in this restricted behavior and interest, repetitive behavior and interest category. And sensory differences falls under that category. It is certainly possible, you know, and it certainly is the case that many autistic people struggle with misophonia as one specific expression of a sensory issue, but it's one very specific type of sensory issue. Autistic people also often have, for example, hyperacusis, you know, loudness sensitivity. And so when you're looking at someone if you're wondering if they fall on the autism spectrum, you're looking at all of that. And with misophonia, at least as we understand it based on the consensus definition that I use and a lot of people use, is it's really narrowly focused on these major emotional and sensory reactions to specific repetitive sounds and their associated visual triggers.
Thank you. So our next question comes from Christoph. Does misophonia always come with other mental or psychological ailments?
Not always. Not always. And there's been a handful of studies that have asked that exact question. Dr. Rosenthal and his colleagues did one at Duke, and they found that the majority, but not all, had some co-occurring mental health condition, anxiety and depression being most common. We found really similar results in a group of about 100 kids. And that's been found in one or two other studies. There's one really large study that did a really thorough job of this that found actually quite low rates overall of co-occurring mental health conditions. This was done in Amsterdam. But overall, it seems to say most, but not all.
Right about a minute and a half.
All right, this will probably be the last question. From Vanessa, can you talk a bit about the controversial role of exposure in therapy?
Yeah, 1 minute on that one. That's tough. How to sum that one up? I'll have a hard time reeling myself in on this one. It is not a good idea to take a very traditional exposure therapy mentality, listen to these sounds until you get used to them perspective. Many advocates have expressed how unhelpful and sometimes worsening that can be, and finding new ways to approach sounds that make you uncomfortable in ways that help, I think is an important part of an overall treatment plan. How can I begin approaching situations that I feel I'm missing out on in my life because of my sound sensitivity? How can I help myself do that? I do think that's an important component, and you might even sometimes call that exposure, but I think approach-based coping is a better way to think about it.
All right.
As one element of a broader treatment plan.
Great, we're at time. You want to wrap up, Grace?
Thank you so much, Dr. Guzick, for joining us today. And
Thanks for having me. I'm thrilled to be here, and thanks for your questions.